Welcome back to the podcast for Advancing Healthcare Through Simulation, and I'm your host, Lisa George. Today we welcome Dr. John Gilbert. He has been a seminal leader in the education of health professionals in British Columbia, Canada, and globally. His vision and leadership led to the concept of interprofessional education being developed as a central tenet of collaborative, person-centered practice and care. Dr. John Gilbert is the founding director of the School of Audiology and Speech Sciences, and also the founding principal for the College of Health Disciplines at the University of British Columbia. He is a senior scholar for the World Health Organization and Collaborating Center on Health Workforce Planning and Research, as well as he is the founding chair and honorary director for the Canadian Interprofessional Health Collaborative. John has been involved in so many institutes, all focusing on interprofessional education, and we're very excited to speak with him today. Hi, John. Thank you so much for joining us on the podcast today.
It's my pleasure. It's always great to talk with you. I think it's a wonderful program that you're organizing, and I'm happy to share my thoughts and ideas and excitement.
All right, so to get us started, John, I was wondering if you could just give us a little bit of a foundational knowledge around interprofessional education and why it's critical for the healthcare workforce development.
Well, of course, we could take maybe 4 weeks to answer that question, so I'll try to do it in about 7 minutes. If you think back to the beginning of the 20th century, there were maybe 4 major regulated health professions, medicine being the chief one, nursing, pharmacy, and something which at that time was called the almoner, but is actually social work. And in the 20th century, you see the development of many, many, many other health occupations, which is what Statistics Canada calls us, health occupations, not health professions. So in Canada, we have about, I think now in StatsCan, there are about 85 occupations. Now, so as those programs developed and became regulated, they built walls around themselves, which got thicker and thicker and thicker, so that they never talked to each other. Very interesting. And the consequence was that there was less and less attention really paid to patient safety and the quality of care, because in my view, those occupations, those professions were more interested in the profession and its development than they were in the care of the patient. I mean, that's being a little excessive, but I think it actually is reflected when you look at the national review that was done in the United States, the medicine review on To Err is Human, where you saw something like 85,000 unnecessary deaths in the United States. And many of it attributed to the inability of professional groups to communicate with each other. And so around, I think, the kind of 1980s, after the production of a big report by the World Health Organization, which preceded the one that I co-chaired, and it was called Learning Together to Work Together. A very interesting title, which we've used over and over and over again, as you know. And a realization that because of the development of these incredible number of health professions, health occupations, people in the academic community better think seriously about learning together in order to get them to work together in order to reduce the number of adverse events. And it's too bad that they were called medical errors, because there was a lot of blaming and shaming as a consequence of that. But in the middle 80s, a wonderful family doc in Britain, his name was John Horder, recognized the work that had been done at my university, the University of British Columbia, by the Dean of Medicine called Jack McCurry in 1964-65, when he wrote the original paper on interprofessional education. So John put in place an organization which is known as the Center for the Advancement of Interprofessional Education. And that kind of moved around and grew and little and grew a little and grew a little until it actually developed a very strong definition of interprofessional education for collaborative person-centered practice. And that definition is, when two or more health professionals or health students learn with, from, and about each other, in order that they can collaborate better, in order through that collaboration to produce much better quality of care for patients and the services that underpin that quality of care. And that definition is held, I think, pretty well and is now used extensively throughout the world because I go all over the place and I see it being used and I keep promoting it because it gives us an anchor for what it is that we're trying to do. It's a testable definition. So many of the questions that you propose to me are really rooted in understanding what that definition is, and then how it's come to affect the way in which we look at the competences necessary to be interprofessional. So I promised you 7 minutes and maybe it was 10, I don't know.
That's great, thank you. With the current status of healthcare right now, and you alluded to it, where we're seeing more and more specialization in the roles, how can interprofessional education through simulation help break down those barriers and work through collaborative practice, communication strategies?
Yeah, well, I think that the development of simulation exercises, and now, of course, the mannequin-based simulation has been an incredible development in healthcare. I mean, absolutely incredible in the education of health and social care professionals. We didn't have a mechanism prior to the kind of notion of simulation that really presented us with opportunities where students and professionals could be together to learn together. They just didn't exist. So it's not surprising that when you look at the way in which the health and social care system is organized, there were these silos. The silos grew out of the silos in the universities and colleges, and then they transported themselves into the practice sector. So simulation has been, in my view, absolutely amazing, and I see it now in many places around the globe, not just person simulation, but mannequin simulation. In fact, I was on a call with one student that I co-supervise in India earlier this week, who is using an amazing simulation program to reduce the number of airway deaths, which occur when, you're putting something down inside and because of oxygenation, it catches fire. In India, they lose about 650 people a year because of these fires. But she's using simulation, mannequin simulation, in a brilliant way. We couldn't have done that before. There's no way we could have, simulated those fires and then, the emergency that goes around it, et cetera. And then if I look at what we've done aside from mannequin simulation, where we do group simulation of work, as you know, that has been really effective. And it was triply or quadruply or 100 times effective in COVID. Because in COVID, we had to find ways online of putting groups together and then kind of developing these mechanisms for learning together. So I think, and we were only just a short way along this path. They're going to be, if you look at virtual reality and those kinds of things, it's going to be huge. And, anybody who thinks that we're going to be where we are today in 9 months' time, they better forget it, because AI is coming in, and we're already seeing large language models influencing the way in which we present data, and then the way in which we can use those AI models for improving the way in which we do group simulation or the simulation of mannequins. So, I think it's just the future is just totally unclear, but it's going to be a very interesting future.
And let's talk about that. What do you see as the forefront of interprofessional education around communication strategies. So what are people focusing on right now and implementing in their curriculum?
Yeah, we all know that, communication is the big issue, right? So we all talk about it all the time. And oh my gosh, if only X had spoken to Y, etc. I served on the BC Patient Quality Council for 7 years. I was appointed by the Minister of Health. And we looked at complaints that were made about the BC healthcare system, of which there are about 80,000 a year. But they range all the way from, oh, why is the food so bad in the hospital, to really serious complaints. And what we saw when we looked at the serious complaints which came to our board was that 75% of the time, it was because communication had broken down some way. Somebody hadn't spoken to the patient, period. And then somebody had spoken to the patient, but spoken the wrong things to the patient. So we spent a considerable amount of time, and we're still spending a lot of time talking about how to improve communication skills. And it's a huge area. I gave a talk in India a couple of weeks ago. And I was talking about listening. We talk about communication, but we kind of forget that the first thing you have to do is listen. And it's unbelievable to me. I never, ever gave a tutorial or a seminar or whatever to our students on listening. You think, duh, first of all, you have to listen, and then maybe you can talk. And at the moment, what we do is a lot of talking and not much listening. So the way in which we see this folding out, particularly in practice settings, is courses on communication. And I don't think, when I read the questions you were asking me, I don't think we as yet have really good data on how effective that communication training is downstream. Because what you want is to see, when you do these skill building exercises around communication, you want to see that 9 months downstream, 2 years downstream, 10 years downstream, which we won't get to, there has been a clear effect on, for example, the reduction of adverse events. Just think about medical errors. I shouldn't say medical errors. Medicine errors. Okay, just think about the number of errors that have occurred because, and don't occur as much anymore, because a pharmaceutical company decides they're going to use X, Y, and Z to start, the name of a pharmaceutical, or they get put in the cart in acute care, but in the wrong order. Mm-hmm. So the communication around that is absolutely vital. And if you go to the OR and you look at the way in which looking at the instrument display in the OR and the color coding and the size of the places to put it back, hopefully we're leaving less sponges inside of patients now, right? Because we've worked out that you want to say, the surgeon wants to say, give me the, and it goes back to where it was taken from. And that's a communication skill. And well, I have a lot of stories about that. But anyway, yeah, communication is huge, but I think listen first. Learn to listen and reflect before you say, oh, now what's the next thing?
Yeah, and with, more technology, more devices, communication is changing, I think, for different generations in the way that we engage in our communication practices. So have you seen more of an emphasis coming back to those basics around communication, closed loop communication, those types of things?
Well, I think the orthogonal is the social media. That's really driven the whole notion sideways, because everything's done here. I mean, when we look at, if I look at my campus and I watch the students, 9 out of 10 of them are here all the time. Well, that's a different kind of communication for people of my age and, my generation of training, etc.
Well, we are seeing differences as well in the healthcare setting now with things like electronic medical records and the documentation as a part of those systems too. Do you see that impacting collaborative practice or enhancing?
Well, I'm in two minds about the electronic health record. A, it's a good thing, but B, it's not a good thing. First, I worry that we have spent billions of dollars in Canada on trying to develop a universal health record, as you know, electronic health. But now we don't have that. We have a very fractionated system. We have practices, family practices, where they have their own electronic health record. We have a whole district where they have their own electronic health record. And ideally, what we want is something, that we can insert a chip in our wrist, and wherever we go in Canada, the chip is used for, and that's not coming. I don't think it's coming. And I worry about the same thing that I worry about the chart. I think the chart is a fantastic teaching instrument, but when you look at the way it's used, the old paper charts were used, the docs would read the docs notes, the nurses would read the nurses notes. Very few people would get to the pharmacist notes or the social workers notes. And when we were doing work on patient quality, care quality in BC, what we discovered was when we were trying to resolve the issue, it was those parts of the record which gave us the most information about how to resolve the problem that had come up. And it's much harder to do it with an EHR, electronic health record. We would have a hard time kind of going in there and kind of looking at it all. But, one has to say it must have promise, but I think it's an unrealized promise yet because of this kind of fractionation, as I said, in the EHR systems. There are, I think, other ways that, I remember when the BlackBerry first came in, we gave BlackBerries to every one of our medical residents. We said, this is the future. I'm not sure. But I do think that having access, within the acute care system, I'm not talking about mental health or outside of the acute care, but having access to immediate information. So I use something called Perplexity, and I think you do as well. It's a great device. You can kind of go, tell me about. And if we can do that, then, somebody on the ward says, oh gosh, I've never seen this before. Dial it up and let's take a look. And it's absolutely phenomenal. It will be absolutely phenomenal. I was at a talk last night given by a bunch of immunologists, a retiring professor, a middle professor, and then 2 graduate students. And they were talking about the amount of data you can put into the system now and get a 5-minute response in 5 minutes that originally it would take 20 graduate students to 6 months to collect. That's really exciting. You can put stuff in and maybe get something out pretty fast, but
wow.
It's just exploding. And I'm always excited about what I see, despite my age and whatever, because I think that it will change the way in which we work interprofessionally. Because now you can go and say, tell me about the interactions between nurses and pharmacists. I mean, just a big, do they in fact, blah, blah. Yeah. Well, I am the president of Hopeaholics Anonymous, as you know. So, I just think we've got a great future in simulation, but it's not. Simulation is very narrow now, right? It's because it's AI. It's the whole thing which is informing simulation, and it's informing other parts of the way in which we teach and which health and social care professions practice.
What recommendations would you offer for those that are looking to build out their interprofessional education through simulation? Are there, how can they align with the real world health workforce needs of today?
Well, there are now, you can dial this up very fast. There are now lots and lots of case studies of using simulation, and then the interprofessional activity. I mean, I must have like 20 references in my Mendeley database. And also, you can, so I see that if you really want to move ahead in the way that you've just asked the question, you have to read the literature. You have to do the search. You have to read it intelligently, thoughtfully, and reflect on whether what you're reading would work in your situation. Because one size doesn't fit all, as we know. You can't do it all. And that's a step that people, I don't know, they take. So when I teach in India, I say every day you have to read a paper on. I say it's not so hard, read a paper. And so if you want to do this, you've got to be prepared to read what's being done now and reflect on it and figure out, as I said, your local situation. Will it work for you? And if not, look at another paper and say, blah, blah. Or do a search, use Perplexity, do a big search, and you'll find stuff. But you can't do it without preparing, by reading what has been done already, if you're starting from square zero, okay?
Well, John, I want to really thank you for you sharing your knowledge, your expertise in the area of interprofessional education and simulation. And we're looking forward to, hopefully connecting again in the future. And thanks so much for sharing your thoughts.
But yeah, all my relations. Thank you.
This series is proudly produced by the team at Road 55. Road 55 creates content that connects. For more information, visit our website at road55.ca.